Hello, on behalf of the Saskatoon Industry Education Council, I want to welcome you to our Spotlight on Careers event in partnership with the Gairdner Foundation. Thank you to the sponsors who help make events like these possible. Especially thank you to RBC Future Launch, the Government of Canada, CIHR, the Globe and Mail, and the Azrieli Foundation. We acknowledge we are on Treaty 6 territory and homeland of the Métis. We want to welcome students, parents, and teachers from across Saskatchewan joining us today. For the past 2 decades, the Saskatoon Industry Education Council has bridged the gap between Saskatchewan school systems and employers, providing experiential learning and career development opportunities for Saskatoon and area youth. As a registered nonprofit organization, the SIUC works in partnership with 3 school divisions and the Saskatoon Tribal Council, as well as community-based organizations, government agencies, and employers to help nurture the workforce of tomorrow. Last year, the SIUC worked with over 30,000 youth, over 3,300 business and post-secondary representatives, and more than 450 educators and career practitioners. Every year, the SIUC hosts over 40 events and programs, including our Spotlight on Careers, which are events such as this, which are a series of targeted events providing students with experiential learning. Our Skills Boot Camps, which are programs that provide students with hands-on experience in various career paths. Our Connected event, which is happening next week, a women mentorship program connecting females in grades 10 through 12 with mentors from a wide variety of sectors in Saskatoon. And the Summer Youth Internship Program, which is a 6-week paid internship where students gain work experience in construction, manufacturing, automotive, and culinary industries, and students earn competitive wages as well as high school credits throughout the 6 weeks. So please visit our website, saskatooniec.ca, or follow us on our socials to stay up to date. At the SIUC, we feel it's just as important to discover what you do not want to do as it is to discover what you do want to do as a career path. So if you're not sure what you want to do after high school, we highly recommend you attend a few of our events to discover what's involved in various career pathways. Throughout our event, please utilize the Q&A function to ask any questions you may have of our presenter. And the SIUC is fortunate to partner on this event with the Gairdner Foundation. And we partner with the Gairdner Foundation every year to bring our Spotlight on Careers events exploring medical research. So you can check out our website to see our event from last year. And if you are in grade 10 or 11, be sure to tune in next year for our Gairdner event. So here's a short message from Dr. Janet Ressant, the President and Scientific Director at the Gairdner Foundation.
Hello, and welcome to today's Gairdner National Lecture. I'm Janet Ressant, President and Scientific Director of the Gairdner Foundation. At Gairdner, we're best known for the prestigious Canada Gairdner Awards, which we've been awarding for over 60 years. 395 awards have been made, 97 laureates have gone on to receive the Nobel Prize, including this year with Dr. David Julius. We're delighted to be able to bring our laureates to speak at universities across the country, where they inspire us all to greater heights in our own research. Our laureates this year have made discoveries that have had an impact on millions of lives around the world, from diabetes to breast and ovarian cancer to zoonotic diseases. The reach of their research is truly global. Your Gairdner National Lecture today is part of a series of virtual events happening from coast to coast as part of Gairdner Science Week. Please visit our website at gairdner.org or check out our social channels at Gairdner Awards to see the full schedule and register to be part of an exciting week of outstanding science. I'd like to thank our sponsors, the Government of Canada, CIHR, the governments of Quebec and Alberta, and the Globe and Mail for their ongoing support of our programs, as well as other sponsors listed on our website. Their support makes events like this possible. I hope you enjoyed today's talk and that you'll join us for all the other fantastic programming that Gairdner Science Week has to offer. Thanks and enjoy. Hello.
So thanks again to the Gairdner Foundation for supporting this event. This year, we will hear from Dr. Elizabeth Eisenhower, the 2021 Canada Gairdner Whiteman Award recipient, as she shares highlights from her career in cancer research. In 1982, Dr. Eisenhower became the director of the Investigational New Drug Program for the NCIC Clinical Trials Group, where her major responsibilities lie in identifying and bringing into clinical trial novel cancer agents. In 2012, she left the NCIC CTG to become head and professor of the Department of Oncology at Queen's University and program medical director of the Cancer Centre of Southeastern Ontario at Kingston General Hospital. Dr. Eisenhower has served in numerous national cancer research leadership roles, including president of the National Cancer Institute of Canada from 2006 to 2017, and chair of the Research Advisory Group of the Canadian Partnership Against Cancer. In 2012, she became its expert lead research, which includes the role of co-chair of the Canadian Cancer Research Alliance from 2008 to 2017. Most recently, Dr. Eisenhower served as a head and professor for the Department of Oncology at Queen's University. She's also received numerous awards, including in 2002, the O. Harold Warwick Prize for the National Cancer Institute of Canada, the Society of Gynecological Oncology of Canada Presidential Medal Award in 2010, and the NDD Award Lecture at the International Conference on Targeted Anti-Cancer Therapies in Amsterdam in 2012. That same year, Dr. Eisenhower received the Queen Elizabeth II Diamond Jubilee Medal for her tremendous commitment to advancement in cancer therapy, supportive care, and prevention across Canada and internationally. In 2015, she was elected a Fellow of the Royal Canadian Society of Canada. In 2017, she received the Exceptional Leadership in Cancer Research Award from the Canadian Cancer Research Alliance, and she was named an Officer of the Order of Canada in the 2018 New Year's list. Please welcome Dr. Elizabeth Eisenhower.
Thank you very much, Michelle. I'm delighted to speak to you all today. And my only regret is that I can't be there in person because Saskatchewan is one of my favorite places to visit. So I'm going to take you through a little bit of a journey that I've called the Accidental Oncologist, a tour through a career in cancer research. And what I will talk about today is really walk you through what happened between my childhood and getting to the position that Michelle mentioned, the director of the Investigational New Drug Program, but then spend some time on cancer research and the progress that has been made over 35 years, outlining how theories of what cancer is have evolved and how new treatments have been discovered, what clinical trials are and why we need them, and then focus on a few examples of what Canada and my work has contributed to clinical trials, hopefully leaving time for your questions. So I called this an accidental journey, a series of chance events. The only thing I knew for sure very early on in my life was I wanted to go into medicine. And I dug up this old one-year diary from 1964 when I was 10 years old. And I found this entry on February 18th of that year. Today, I decided I'm going to be a doctor when I grow up. And I really didn't waver from that thought, although I did have a backup plan to be a paleontologist if I didn't get into medicine. Some years later, I was graduating from high school in Ottawa, and I had applied to the pre-medicine programs of a few universities, and I was accepted into both Queen's and Western University for pre-medical training. In terms of trying to decide which one to choose, it was not terribly difficult because Queen's was a bit closer to my home in Ottawa, and I started university there in September of that year. And sadly, a month after I started, my mother died of breast cancer, an event which undoubtedly shaped some of my future career decisions. In the second year of medicine, my first exposure to clinical skills in patients brought to me the first chance encounter that began to shape where I went next. My small clinical skills group leader was a physician named Dr. David Ginsberg. Now, these groups were groups of 8 medical students, and each group of 8 had a leader and some teachers that taught us how to examine patients and take histories and really begin to discern some of the issues in clinical diagnosis. Well, Dr. Ginsberg was a hematologist and a fantastic mentor. And as often happens along the way, working with someone you very much admire makes you very interested in doing the same type of work that he or she does. So following this, I really had my sights set on training in hematology. In 1979, I was in the midst of my hematology training program, having completed internal medicine training. And the second chance event, if you will, happened. By default at that time, hematologists started to see actually all cancer patients, not just those who had blood cancers like leukemia and lymphoma, because oncology as a specialty was not yet designated. And looking after cancer patients, I found this always inspiring, though of course sometimes sad. And furthermore, the late 1970s was the beginning of a real change in how we could manage cancer. New cancer drugs were becoming available, which started to make it a treatable disease. And there were some pretty dramatic effects seen. And in that series of encounters looking after cancer patients in the middle of my hematology training made me very interested in helping to investigate new treatments for cancer. And the third chance event, I guess, was that in 1980, the Canadian Cancer Society decided to establish a national clinical trials group through the National Cancer Institute of Canada. And that group was intended to knit together a network of cancer centers and hospitals from coast to coast to undertake clinical trials of cancer therapy. And there was a competition for the director of the group that year. And the person selected was Dr. Joseph Pater, who was a hematologist oncologist based at Queen's University, one of my mentors and teachers. And because he was already in Kingston at Queen's, rather than move to Toronto, he moved the group to Queen's. And a couple of years later, when I finished my training, because I was aware of this new office and new position, I was offered the position of a director of the Investigational New Drug Program. So those 3, if you will, chance events, the mentors I had, the kinds of patients I looked after, and the event of the Canadian Cancer Society selecting Joe Pater to run the new NCIC CTG and base it at Queen's were what really shaped the directions I took. In 2016, the NCIC CTG was renamed the Canadian Cancer Trials Group, and that's how I will refer to it through most of my presentation. I'd now like to switch gears a bit and talk a little bit about cancer research and the progress that has been made over 35 years. But first, let's go back in time and really try to understand how long cancer has been with us. And the answer is it's been with us for millennia. As long as we've been here, there has been cancer. One of the first documented cases of breast cancer is from 500 BC, 2,500 years ago, where the Persian queen Atossa was described as having a tumor on her breast. And that story and many others chronicling the story of our understanding of cancer and how treatments have evolved is found in this fabulous book by Siddhartha Mukherjee, which anyone can read. He refers to cancer as the emperor of all maladies, and the book is a biography of cancer. And I recommend reading that if you want to find out more. The theories of what cancer really is have evolved a great deal over time. Going back to the ancient Greeks, Hippocrates espoused the humoral theory of cancer. At that time, it was believed that the 4 humors, blood, phlegm, yellow bile, and black bile, had to be in balance in the system to produce a healthy individual. And cancer was a result of an excess of black bile. And it was 1800 or more years later before that theory changed, and the lymph theory of cancer in the 1700s became prominent. In that theory, cancer was thought to come from fermenting lymph, which is a fluid that flows through the lymphatic system like blood flows through blood vessels in the body. In 1838, the German pathologist Johannes Müller first demonstrated that cancer is actually made up of cells that look abnormal. And he proposed that cancer cells arose from budding elements, so-called blastemas. But the final person who really got it right was Müller's student, Rudolf Virchow, who identified that cancer cells actually arise from other cells. And that really has been where our understanding of cancer has laid since that time in the 19th century. So in fact, if cancer comes from our own cells, cancers really are us, just gone wrong. And that is the root of the conundrum about how best to treat cancer, because if cancers are us, how do we treat a cancer without harming ourselves? The obvious question to start with is, what is the cause of cancer? What makes our own cells turn on us and go wrong the way it does? And one of the big reasons for looking into the causes of cancer, of course, is once you understand why cancers might be provoked or arise, then prevention strategies may be possible. And while you don't always find a reason for why a particular individual has developed a cancer, we know that in general, many things and exposures increase the risk of getting cancer. Prominent amongst those are both viral and chemical carcinogens. Carcinogen, a word meaning cancer causing. And the biggest of those is tobacco. Smoked tobacco increases the risk substantially, not just of lung cancer, which most people know about, but also cancers of the larynx or throat, bladder, breast, pancreas, and more. And in fact, 1/3 of all cancer deaths today can be traced back to tobacco exposure. Other things that cause cancer include asbestos. And one of the reasons that asbestos isn't used anymore in shipbuilding or in home construction is that it's a cancer-causing substance. Radiation. So radiation from sunlight causes skin cancer. Radiation that's more penetrating, such as the radiation exposure that survivors of the atomic bomb in Hiroshima led to cancers such as thyroid cancer, breast cancer, and leukemias. And really important is that some viruses, viral infections, can many years later cause cancer. Prominent amongst those are the human papillomavirus, or HPV, which can lead to cancers of the cervix or mouth. Hepatitis virus can lead to liver cancer. And thankfully, there are vaccines now available that prevent infections with those viruses and are already being seen to reduce the risk of those cancers arising. But a really important factor that drives the risk of cancer is actually aging. The longer you live, the more times your cells divide in your body, the more chances they are of incurring a mistake, and the accumulation of those mistakes in cell division can lead to a malignant or cancerous state. So if those are the things that provoke, if you will, transformation of cells into cancer, what actually is going on inside the cancer cell to make it behave in a malignant way? And the reason that this is important, and where a lot of research has gone on, is if you really understand what differentiates at a molecular level a cancer cell from a normal cell, perhaps that can be targeted and reversed through treatment. So research has uncovered actually hundreds and sometimes thousands of changes within cancer cells that allow them to do lots of things that give cancer its characteristic behavior. So growing uncontrollably, not dying when they should, invading, spreading, and avoiding the checks that our immune system might normally put on a foreign invader like a bacterium or virus. And all of those things I talked about in the last slide that increase the risk of cancer actually do it through causing genetic damage inside cells that accumulates and starts to develop some of these changes that lead to cancerous behavior. So if that's sort of the story of causes and what happens inside a cell, what about the treatment side of the equation? And I think really up until just over a century ago, cancer treatments were pretty useless and non-existent. But at the end of the 19th century, surgery to remove cancers was made possible by the ability to sterilize instruments and anesthetize patients. And the discovery of radiation also led to the opportunity to treat cancer, although that wasn't really capitalized on until the mid-20th century. And by the way, Saskatchewan was, I think, the first province in Canada where radiation was successfully used to treat cancer. In 1947, the National Cancer Institute of Canada was formed. And at that time, the 5-year survival from cancers was only about 1 in 3 patients. But since the 1940s, lots of new treatments, mostly drug treatments, have improved the survival of patients. And some of these were simply discovered by screening chemicals and extracts of natural products like plants and seeing if anything made cancer cells die. And if so, then developing them further to see if they could be used as drugs. But more recently, treatments are what I would call more intelligently designed to overcome what we know to be the molecular changes driving cancer. Regardless of whether a new treatment might come from a screening system or whether it might come from so-called intelligent design, any proposed new drug treatment has to undergo a rigorous series of research studies in the lab before you can give it to a patient. And I've listed here some of them: testing new drugs within cells and in mice bearing tumor burden, like the picture on the bottom. The other tests have to involve evaluating the toxicity or side effects in animal studies, manufacturing and formulating the drug in safe and sterile conditions, demonstrating which type of dosing or schedules is optimal, and understanding the pharmacologic disposition of the drug and how it's metabolized. All of these studies have to be put together in a large package of information, submitted to Health Canada or the FDA, reviewed, and only then can clinical testing in humans begin. In terms of the clinical side of research, so-called clinical trials, the clinical trials done in the study of a new cancer drug undergo a series of stepwise investigations. The very first or first in human phase 1 trials usually involve only 10 to 30 patients. And really the goal there is to understand if the drug can be given safely, and you start at a low dose and gradually increase it, and understand what the toxicity or side effects of the drug are. And this work is to determine the best dose to study further. Then phase 2 trials begin, where studying that best dose in a specific types of cancer is undertaken. And there we're looking in smallish numbers of patients to look for any sign that that new drug has activity. And the sign we're looking for is usually shrinkage of tumors in patients who have advanced cancer. And as an example, here's a CT scan slice through the chest. So the middle blob is the heart and the dark areas are lungs. And you can see the arrow pointing to a solid mass in the lung on the left side of this picture. And after treatment, it's shrunk down considerably, and that's called a partial response. And that's the kind of thing that we look for in phase 2 trials. And if we see that in enough patients, we get the idea that that new drug maybe really could have an impact on cancer. And then the final phase of investigation is really to add that new drug to standard treatment and compare it to the standard of care alone to see if it really does improve survival or cure rates. And those are randomized phase 3 trials that take hundreds or even thousands of patients. And what I spent most of my time doing in my 35 years in cancer research was phase 1 and 2 studies, but I did do a few phase 3 studies, and I'll give you an example. So you've heard a little bit about the various phases of clinical research, but what really is a clinical trial? Well, clinical trial is an experiment. It's an experiment to evaluate a new drug or a new therapy, could be surgery or a new kind of radiation in cancer patients. And these are not fly-by-night endeavors. They're rigorously undertaken using a research protocol that clearly defines who could be treated, what and how the treatment is given, how to measure and document results, and what the analytical, statistical, and reporting plan for the research study is. Clinical trials are not undertaken by just anyone. Clinical investigators have to be trained in research methods and in best practices to undertake trials, to be allowed to put patients on. And there are ethical oversights where any institution who wants to put a patient on a clinical trial needs to obtain ethics approval from their research ethics board. And Health Canada in Canada has regulatory oversight, as I mentioned, that they have to approve each trial before it can start. And what Health Canada looks at is not just whether it looks like it's safe and it's reasonable to do this study, but also whether the manufacturing has been undertaken in a way that the product will be safe and sterile. So why do we need trials at all, you might ask? I mean, if we're testing these things in animals and in petri dishes and you look like you've got a slam dunk, why do you need to go through a testing phase? Why can't you just use it? And the answer to that question is that even though we're pretty good with our animal models and finding things that look exciting, we are disappointed often enough in how things behave in people to know that we can't use animal studies or laboratory studies as a guarantee of what's going to happen in patients. And here's an example from way back in sort of 20 years ago when we were doing a trial in ovarian cancer, and we got very excited by a drug called a matrix metalloproteinase inhibitor, which seemed to stop cancers from growing and spreading. And here it was given to mice who had ovarian cancer. And the dotted line sort of heading straight south reflects the mice who were given nothing or just saline, I think. And they very, very quickly died of their tumor. So by day 20 on the bottom, all of the mice in that treatment group were dead. Whereas the mice that got the MMPI drug, although they gradually died, they really had quite a major impact of treatment. So we took this exact same drug into women with ovarian cancer who had completed chemotherapy, and we thought, maybe it can prevent recurrence of their cancer. And the kind of effect we saw there was very different, minimal to no effect. So this just illustrates why we can be excited by mice studies, but we can't completely bank on them. We still need trials. So in the last few minutes, I'm going to talk about some examples of clinical trials that were done by the Canadian Cancer Trials Group. I personally was involved in about 170 clinical trials over the years, and I've just picked 3 examples. 2 of them were mine and 1 from my CCTG colleagues. So the first of them has sort of got a bit of a Western Canada flavor. A guy named Dr. James Johnson, who's a hematologist in Winnipeg, was doing studies in his lab on a rare leukemia called hairy cell leukemia, which under the microscope, as you might imagine, the leukemic cells look very hairy. And there wasn't much effective treatment for it back in these days. And he found that a drug in his lab called Deoxycoformycin really looked very exciting. And we did a phase 2 study in Canada and saw that 100% of patients who received this drug had some improvement in their disease, and close to 90% of them had a complete remission of all leukemia. And by chance, I was a hematologist practicing in Kingston, as well as doing my job with the clinical trials group. The very first patient enrolled in the trial was mine. And this gentleman was, I guess, fortunate enough to have his diagnosis made just as this trial was opening. And he came to me having a massive spleen, an organ that's normally tucked right up under the left side of the rib cage, and you can't feel it. And you could feel his spleen down below his umbilicus, and his bone marrow was full of tumor and he was exhausted. And after just 3 doses of deoxycoformycin, each a week apart, his spleen was normal size and his bone marrow had begun to show return to normal. And there was really, this was an exceptionally exciting moment for me personally, but especially for this gentleman. The second example I'm going to talk about is a drug called Paclitaxel or Taxol. Now, Taxol was one of the drugs discovered through the US National Cancer Institute screening program. In the 1960s, they made an agreement with the Department of Agriculture in the United States to just collect samples of leaves and trees and bark from plants across the United States. And they would make extracts of these various samples and test them against some leukemia cells in the Petri dish. And the extract of the bark of a tree called the Pacific yew or Western yew was very active in this assay. And it turned out that when they purified this, it was a very complex chemical structure. You can see in the bottom left of your screen just how complicated it was. Makes you wonder why the yew trees needed to grow that. But it was very active in cancer cell lines and in models, and it seemed to have a pretty new mechanism of action. So after a few years, it took a long time to figure out how to get this into solution to provide it to patients. It was started in phase 1 trials in the United States. And these phase 1 trials of Taxol hit a lot of bumps in the road at first. First of all, when they were infusing this drug, it caused severe allergic reactions. It also produced cardiac effects, slowing of the heart rate, requiring patients to have a heart monitor on them. And while normally this might have been a bit of a death knell for this drug, the fact that a few of the patients in these phase 1 studies with breast and ovarian cancer showed quite early on that their tumors were shrinking made people want to figure out how to get around these problems. So they tried a few things. They added pre-medication, drugs given before the infusion, such as steroids and antihistamines, to try to block the hypersensitivity reactions from appearing. They prolonged the infusion to 24 and 72 hours to try to give the drug more slowly to make it safer. And they monitored the heart rate continuously. And this seemed to help, but it would mean if that were how we give the drug, patients would need admission to hospital. And it was a pretty tough way to be trying to test a new agent. So in Canada, we were pretty interested in figuring out whether we could make it safer and easier to give the drug. So our first study of Taxol in Canada was one where we proposed randomizing patients with ovarian cancer to 2 different doses and 2 different schedules to try to see if we could pick the best way to give the drug. And we did this randomized trial in collaboration with our European colleagues. So this kind of double randomization or 2x2 design or bifactorial design looks something like this. So each patient would be randomized to either a low or a high dose, 135 or 175, but they would also be randomized to receiving the drug either for 3 or 24 hours. And we analyzed the 2 schedules as a separate analysis from the 2 doses. So any individual patient would only fit in one of these boxes, something like that. And what we found out was, to everyone's surprise, that the shorter infusion, not only was it safe, it was safer than giving the drug in a prolonged way. Furthermore, that higher doses were better. And this changed how Taxol was given, not only in Canada, but around the world. And it also led to 2 important developments beyond that. One of them was that we worked with the Europeans to design a new study where Taxol was given frontline in ovarian cancer instead of in recurrent disease. And this produced, at least for those days, a pretty dramatic improvement in survival for ovarian cancer patients. Women lived on average at the median 1 year longer if they received Paclitaxel up front. And the final example I want to spend a moment on with you is a more of an intelligently designed drug. And that is a drug targeting the epidermal growth factor receptor of cancer cells. Now, as I mentioned a few minutes ago, the lab research in the 80s and 90s really started to show us that cancer cells have many abnormalities, and some of these abnormalities related to the surface receptors on cells that seem to be involved in driving cell growth. And one of those receptors is the epidermal growth factor receptor, or EGFR. And it turns out it's mutated or overexpressed or abnormal in a number of different cancer types. And the epidermal growth factor receptor is actually the start of a signaling pathway, as you can sort of see on the right here, that drives cancer cell growth. So it kind of made sense that in a way, the EGFR pathway was kind of overactive because of these mutations and abnormalities. And it was kind of like trying to stop a car when the foot is pressed down on the gas pedal. So the EGFR pathway was like the foot slammed down on the gas pedal. And maybe if we could interrupt it or put the brakes on, we would slow the growth of cancer. So a number of different drugs were developed to target the receptor and block its activity. And within our phase 1/2 program, we did a number of different trials with EGFR inhibitors, but it's actually a phase 3 trial I wanted to talk to you about. This trial looked at the EGFR inhibitor Erlotinib in lung cancer. And in that trial, lung cancer patients who'd exhausted all forms of therapy were randomized to receive either Erlotinib or a placebo, both of them oral tablets. And it was the first trial to show that an EGFR inhibitor improves survival in lung cancer. And furthermore, the tissue we got from patients enrolled in this trial helped us understand exactly which patients we should be giving this drug to. So those are 3 little stories of trials that we've been involved with that seem to help patients. So in general, though, how are we doing with cancer, and are things getting better? Although cancer remains, I think, a very important cause of death and suffering around the world, the outlook for some cancers are improving. Now, I told you back in 1947, only 33% of patients on average lived 5 years. That's now 63% of patients diagnosed today. So there's an improvement overall. But for some cancers in particular, you see colon, breast, and prostate comparing sort of 30 years or so of progress, quite dramatic improvements in 5-year net survival. But there's still a lot of work to do. So what I hope you've learned is that in terms of my career, it was really a decision to go into medicine that was taken early, but a series of chance events while there that led to my involvement with the Canadian Cancer Trials Group in cancer research. I feel really privileged that I was able to spend 35 years of my work in cancer care and research, and that some of the research I was involved with has led to better patient outcomes. Clinical trials really aren't easy, but they are a critical final step to evaluate new treatments for patients. And although it's always great to talk about the exciting new things that we're finding that change things in a positive way, it's as important sometimes to know early when treatments are not going to be successful, so we don't waste time and we don't involve more patients than needed in testing them. So I'd like to conclude by thanking literally thousands of patients and families for their commitment and courage. Every patient on the trials that we did volunteered to be part of those trials, many of them with the hope that not just for themselves, but to make cancer outcomes better for future patients everywhere. The Canadian Cancer Society in particular has supported the Canadian Cancer Trials Group now for 41 years, and funding from other organizations shown here has been important. We've had to partner with pharmaceutical industry where a lot of those new drugs come from to be allowed to test them in patients in our trials. And of course, investigators and institutions across Canada and around the world. And I will end there and invite you to ask any questions you want. Thank you.
So Dr. Eisenhower, we have a few questions for you. So the first one from one of our attendees was, how do you decide what clinical trials you want to pursue?
Well, that's a great question, because one of the problems, I won't say it's a problem, one of the big changes since I first started in 1982, there was a really, really small community of clinicians like myself interested in new drugs in cancer. Pharmaceutical industry was not interested. Most of these came from labs and academic centers. But now there are dozens and dozens and dozens of new drugs. And the risk of that is, of course, that there are a lot of Me Too studies that consume time and effort and could turn out all to be negative. So the kinds of things I would look at, is this really a drug that is not just a copycat of something we already have? What advantages does it offer over the therapies that we have, at least based on the laboratory studies? Is it a drug that might treat a condition for which therapy is poor? And tumors such as pancreas tumors, glioblastomas, which are brain tumors, esophageal cancers, there's a long list of cancers that I didn't talk about where results have not been so good. So does it look like it's going to be truly new? Does it look like it might affect a disease where we sorely need new treatment? And does it look like it is likely to be safe to give to patients based on the preclinical things? All of those factor into decision-making.
And so how long do cancer and clinical trials usually take?
So it depends. You'll recall I talked about phase 1, phase 2, phase 3 trials. And I would comment that a lot of those lines between phase 1, phase 2, and phase 3 blur a little bit as in our efforts to make things more efficient. But the phase 1 portion of a trial may take a year. And that's because of how cautiously we approach giving something truly new to patients. So the typical phase 1 trial is designed by enrolling just a handful of patients at the lowest dose we think is safe. And then if they tolerate it well, the next few patients get a little bit higher dose. Meanwhile, we're measuring things like pharmacology. We're measuring, is the drug actually affecting the target and so on that we think it ought to. So that may take a year. Phase 2 trials may take a year. And phase 3 trials, if it's thousands of patients, may take several years. Most phase 3 trials, however, are designed in a way to stop early, either for futility. So there's what's called an early stopping rule. If the data emerging from the trial seems to be so negative that it's impossible that the trial will ever achieve what you want, or it's so extremely positive it isn't ethical to continue. And that happens sometimes, but it's not very often. So months to a year, let's say, for the first phases, and then a few years for the last phases.
We have one question from, I believe, a student asking any advice for students wanting to go into medicine.
Yes, well, it's a tough one because going into medicine is very competitive, as everyone knows. There are lots of people interested in doing medicine, which is awesome, but the competition to get there is also pretty strong. I think it's helpful to reflect in yourself what makes you interested about medicine. Is it helping sick people? Is it doing research? Understanding your sort of underlying motivation, but then also saying what besides a medical career could actually satisfy my interest. So you have a series of potential plans. Let me give you an example. I was talking to a high school first-year university student a couple of years ago, and he really wanted to get into medical school. And he said to me, and I asked him that question, why? And he told me a story of when he was about 12 or 13, and he was doing a lot of sports, and he had a really bad sports injury. And he really, really admired the orthopedic surgeon who looked after him and got him well again. And that inspired him to want to go into medicine himself. And so we talked about other career choices besides medicine that might offer him some of those same opportunities to help people with sports injuries, like physiotherapy and rehabilitation medicine, and so on and so forth. So that's step one, I guess, is what are you thinking of when you say you want to go into medicine? What's the why? But then preparing yourself for it. And I guess there's way more advice out there that I can offer. But many people feel that it's helpful to try to get some experience in a medical environment, whether that's volunteering or summer jobs, just so you know for sure what the real life is like. Going into medicine isn't all like it is on the TV shows, that's for sure. So some experience there. Broadening your horizons. Don't be so focused on only science and only medicine that you have only one topic of conversation. Think more broadly, explore the world, experience the world, and do some reading. Very hard to give you a recipe for this because there's no rhyme or reason sometimes why one person's accepted into medical school and the other one's not. But maybe those are a few comments that help.
Thank you, Dr. Eisenhower. So we have another comment and question. So someone said, we are so happy you are saving so many lives. How long was your residency after med school, and what undergrad program did you pursue?
So I'll start with the last part first. When I went to medical school, there were two ways you could get into medicine. You could go right out of high school into a pre-med program for 2 years, and then you were more or less guaranteed acceptance into your 4-year medical school curriculum, unless you really screwed up. And that's the kind of program I got into. So when I left high school, I was in Queen's pre-meds, and after 2 years, I was right in meds. And I know that disappeared. I think our class was the last year that was happening at Queen's. And thereafter, it was sort of an undergrad degree and then a medicine degree. Surprisingly, or maybe not surprisingly, it's flipping back a bit now. I know at Queen's, we have a number of slots reserved for kids coming right out of high school into kind of a pre-med program again. And part of that was that going through medical school is already fairly long, and then going through post-grad training is long again. And you're in your mid-30s by the time you finish your training, and that's a long haul. So the undergrad I did was pre-meds, and that was 2 years of pre-meds. The post-grad training, so I specialized in hematology, and that is a 5-year program, 3 years of general internal medicine, and then 2 years of hematology subspecialty training. And most specialties are around 5 years like that. Primary care and others are shorter, but that gives you a bit of an idea. So 6 years plus 5, it was 11 years after high school.
All right, so we have time for, I think, one more question before Dr. Eisenhower has to move on to her next presentation. So someone asked, did you study certain kinds of cancer like breast cancer or ovarian, or several different types of cancer?
So we did trials across the board. We weren't focused on only one. As it turned out, I got quite involved in ovarian cancer and some other types of cancer. But what we were looking at is what are the new drugs that are coming out of the labs that look interesting, and where is it most appropriate to study them? And let me give you an example. So I talked about EGFR inhibitors in that last example in lung cancer. So if you know a drug's coming out of the lab that might target a molecule on the cell, it's reasonable to say, well, what cancers have abnormalities there? And that drives what trials you want to do. For EGFR inhibitors, it's going to be things like lung cancer, cervix cancer, epithelial tumors that show abnormalities in EGFR and its pathway. So a lot of the times, the cancers we studied were determined by what were the interesting new drugs coming out and what did it make most sense biologically to look at them in. Marry that with a little bit of once you start doing trials in a certain area, like we did, breast, lung, ovary, melanoma, glioma, once you start to do trials in a certain area, you also get to know what are the questions that might be worth asking in that area. So that also creates the need for finding a drug to answer the question as well. But I didn't specialize in only one type of cancer. The program looked at basically everything from soup to nuts, and what tended to drive the tumor types we looked at were what were the drugs that were coming out of the lab and where were they most interesting or most likely to be important given what we knew about the biological differences between cancers.
Well, thank you so much, Dr. Eisenhower, for joining us. And I know you have to get going because you have another presentation.
I do.
But thank you for sharing your career journey with us. Thank you for sharing the work that you've done. I know even from the questions, I think that you've inspired a lot of the participants who are with us today to possibly pursue a career in medicine or in medical research. And I'm hopeful that many students who view this after today will be able to benefit from your words of wisdom that you shared. So thank you very much. And it was a pleasure to get to hear your story today.
Thank you, Michelle. And thank you everyone for attending. And I wish you all great success.
All right. So Dr. Eisenhower has to take off, but before you guys leave, I just have a few things that I'm going to share with you. So first off, I want to thank our partners for helping to put this event together. So as I mentioned, we partner with the Gairdner Foundation every year to bring an event like this to students. And in the past, we used to host this in person, and hopefully one day again in the future, we'll be able to do our in-person events as well. But thank you to the Gairdner Foundation. Thank you to their sponsors, the Government of Canada, CIHR, the Globe and Mail, the Azrieli Foundation, and RBC as well. RBC Future Launch is one of the sponsors of our Spotlight on Careers event. I want to thank my colleagues who helped make this event happen, and thank you to everyone who tuned in today to take part in this career exploration event. I hope that you found it beneficial, and I hope you learned something about the career path that was highlighted today. I do want to encourage both the students who are watching this event, either live or recorded. Please let us know what you thought of the event. We use the feedback that we get from these events to help guide our decisions in the future. So give us some feedback. Plus at the IEC, we love to give out prizes. So if you do give us some feedback, your name will go in a draw to win a prize. So we have our QR code for students, so you can give that a scan. Also, you'll be getting a thank you email for attending the event after today, and it has the URL for the feedback. Teachers, if you tuned in today with your class, please provide us with some feedback so that we know what you enjoyed and what improvements we can make in the future with our event. And I want to encourage you to continue to take the opportunity to map out your career journey while you're still in high school. So this week, as we are focusing on careers in healthcare throughout the month of October, we have some other events coming up. So tomorrow night, we have our Spotlight on Nursing. And for this event, we are partnering with the University of Saskatchewan's nursing program, as well as Saskatchewan Polytechnic's LPN program and the University of Regina's nursing program. So if you're interested in possibly pursuing a career in nursing, you'll want to tune in for that event. So you can register through our website. And then on Thursday night, we are going to be looking at careers in medical diagnostics. So this has become very popular and very important in these times that we're in dealing with the COVID-19 pandemic. So if you're interested in a career in that area, you can register on our website as well. Also on our website, we have a bunch of resources for you that highlight careers in healthcare. So we have a spotlight on dentistry. So if you're maybe interested in the medical field, but this event today made you think maybe not medicine per se, or maybe not medical research, we have our spotlight on dentistry, which is an interview with a dentist, dental assistant, as well as an orthodontist. We also have our nursing career pathways panel that we hosted last year, but this gives you an opportunity to hear from nursing professionals where they share their career journeys, as well as the physician's career panel where they discuss their career journeys. And a lot of you had some questions today about medicine and about what undergrads you pursue and your residency and those types of things. So I would recommend you check out our physicians panel because a lot of those presenters spoke to topics such as that. Also, we do highlight our Spotlight on Career series every month with a different focus. So take a look at our website, check out the different events we have going on. We have live events as well as our recorded events from last year, or recorded interviews and tours. And this just gives you an insight into what those career paths look like. So take a look at our website and see if there's anything coming up you might be interested in. And most importantly, give us a follow. We highlight all of our upcoming events on our social media as well as on our website. So be sure to follow us and stay tuned to what we have coming in the future months.